naš kongres prije čak i službenog otvaranja predavanjem profesora Neta Triestera sa Harvard School of Dental Medicine i Brigham and Women's Hospital iz Bostona. Profesor Net Triester je inače osoba svjetskog glasa, naročito u području istraživanja toksičnosti onkološke terapije u usnoj šupljini. Poglavito uži dio njegovog djelokruga je graft-versus-host disease kod alogenične transplantacije krvotvornih matičnih stanica, a tema koju će nam on predavati danas je takozvani IRAI, to je Immune-Related Adverse Events, koji se najviše temelje na immune checkpoint inhibitors, koji su nova terapija koja se adjuvantno koristi kao kemoterapija i karcinoma usne šupljine glave i vrata, tako da evo sada ćete imati priliku čuti najnovija zbivanja, s obzirom da je njegova bolnica uvijek među prvima koji uvijek neku eksperimentalnu terapiju počnu aplicirati, onda oni prvi ujedno i vide promjene usne šupljini koje nastaju kao nuspojave toga. Evo ga. Nat, you're up and please, we'll enjoy your lecture now.
All right, excellent. Well, thank you, Dr. Alishbeg, and welcome to all of you. I know I hear we have participants, they're dental students, medical students throughout Croatia and the broader region. So I'm really happy to be here with all of you, and I hope you find this course interesting and informative and educational, as well as this talk. And I hope that this talk may stimulate some interest in the field and get you thinking about some things maybe a little bit differently than we typically think about when we think about cancer patients and complications of cancer therapy. So I'm going to start with a figure I like to use when talking about cancer and management of cancer. This is a paper now over 10 years old, but this is sort of a classic paper called The Hallmarks of Cancer, in which all of these various cancer pathways are identified and discussed in detail, and also where various interventions are also highlighted. And so we obviously are not going to talk about all of these today, but it's important that I'm sure many of you are familiar with all of these different aspects of the various mechanisms and strategies for how cancer develops, advances, metastasizes, and so on, resists therapy. And one important mechanism that's been recognized for many years is cancer's ability to avoid immune destruction, because our immune systems, like protecting us from infections, actually do quite a bit to protect us from cancer as well. And so this has been recognized for many years, and it's been over this last 10 years or so where we've really had this new revolution of immune therapy being used to treat cancer. And so I heard Dr. Alishbeg mentioning the term immune checkpoint inhibitors, or ICIs. These are the agents that work to essentially take advantage of our own immune systems and to help sort of harness that energy and power to target and destroy and or control cancer. And this works through a fairly complex system of receptors, as you can imagine, but we can simplify to sort of the most important being this PD-1 and the PD-L1 ligand receptor on the tumor cell. And as you can see here, we have a targeted therapy that's called anti-PD-1 that blocks either PD-1 or the PD-L1. And there's also the CTLA-4 surface molecule, again, this would be on what's a tumor-specific T cell. And by blocking with an antibody again, an anti-CTLA-4 blocking antibody. This allows for the immune response to not be undermined or blunted by these mechanisms of the tumor cell. And as you can see here, if the PD-L1 binds to PD-1, it actually inhibits the T cell from killing the tumor, and by blocking it, you get tumor cell death. Seems very simple, of course, much more complicated. And I would just add that where we are today is primarily targeting either PD-1, PD-L1, or CTLA-4. But this is, as I will mention at the end, a rapidly advancing field. And there are many other targets and and approaches to manipulating and helping to further refine the immune response that I can't imagine how much this field will evolve during the rest of my career because of just the incredible complexity of the immune system. And the reason we're talking about this today is because this therapy has actually demonstrated significant curative potential. And the initial work with the immune checkpoint inhibitors, and in particular the CTLA-4 blockers, has been with melanoma. As you'll see in a minute, that the indications expand much more widely than melanoma now. But these there is a great body of data now demonstrating how effective these therapies can be in really advanced refractory cases of melanoma, where you would expect there to be very poor survival outcomes. And this is a figure showing pooled analysis from several studies of ipilimumab, the anti-CTLA-4 blocker, in advanced metastatic melanoma. And what you see is that it's not entirely effective, of course. Everybody doesn't do perfectly, but you have this steep drop off in survival, and then it just hits this plateau. And these are the responders, and those who respond actually respond for a very long time. Ultimately, it's very unlikely that these patients will die because of their cancer. They'll die from some other reason. And similarly, again, in melanoma, studies that have evaluated the anti-CTLA-4 blocker versus the PD-1 or PD-L1 blockers, as noted here with nivolumab, when you combine these treatments versus just a single arm, you get an even greater response. Of course, with combining therapies, there's also greater risk for complications. And most of what we're going to be talking about over the 15 minutes or so are these complications. So again, this is a rapidly advancing field. This is a really nice figure from about 2 years ago. This list is slightly revised now, but I think for the most part, it's a fairly comprehensive list. And I think the take home here, rather than going through every cancer listed, is I talked to you about melanoma, but you can see there are so many other cancers that have approvals, including head and neck cancer. And again, this is going to continue to evolve and be applied with certainty to more and more cancers, and perhaps applied at an earlier stage, because this tends to be used for the more advanced and refractory cases, not as sort of an upfront treatment for an early stage cancer. And again, I know that the focus of this talk, of this course, is on, I believe, oral and sort of head and neck cancers. And so just to sort of pull this therapy and the complications we're going to talk about into a little bit more relevance, this was sort of the landmark paper published in New England Journal of Medicine 6 years ago now, demonstrating the efficacy of nivolumab in recurrent squamous cell carcinomas of the head and neck. And for any of you who work in this field or starting to gain experience in your training, you will see patients most likely. I don't know how widely this is used in each of the countries where all of you are, but certainly a treatment modality that would be considered for some of our more advanced head and neck cancer patients. So when we talk about the immune-related adverse events, or IRAEs, as you can imagine, we're unleashing the immune system to target cancer. But anytime we unleash the immune system or the immune system becomes overly active, it's never going to act in a very specific way because it's not possible to control the immune system in that manner. And so by turning up the volume or turning on switches or however you want to think about that in your head, we get an effect on the cancer, ideally, although we don't always have a good response to cancer that goes hand in hand with development of side effects. But by activating the immune system, we may be turning things on that have never been turned on for that individual. There may be underlying disease that gets accentuated or further activated, or there may be subclinical immune disease that now becomes clinically evident. And as you can see, this list is incredibly extensive. Almost anything that you can imagine where the immune system causes some sort of pathology to some body organ or system, it has been recognized and described in the context of IRAEs. There are some that are more frequent than others, but it's incredibly widespread. And as we can note here, dry mouth, mucositis are highlighted for the mouth. But all these other conditions that and when you think of the spectrum of immune-mediated and autoimmune conditions that we deal with in medicine and oral medicine, nearly every presentation has been described. And as far as risk factors for developing IRAEs, as noted, patients who have a pre-existing condition are going to be at much higher risk for developing certain complications or complications specifically related to their underlying disease. And as we have gained more experience, as you can see at this point, this was 5, 6, 7 years after sort of the initial experiences with and approvals of immune checkpoint inhibitors in melanoma. There's been a concerted effort to come up with management guidelines. So this is from ASCO, the Journal of Clinical Oncology, and these are guidelines for both how to grade these toxicities and then how to manage based on the grade of toxicity, including dose interruptions and or dose reductions, or even the recommendation that treatment be stopped because the toxicity is so severe that providing further immune stimulation may actually cause such toxicity that it's completely counterproductive. One thing I always like to point out here, so this was a 2017-18, this is a 2020 paper that does recognize dry mouth mucositis here, but I always like that for this was, a big paper, obviously a lot of emphasis on skin rash and cutaneous toxicity, and they recognize that the head can be affected, but this patient has no mouth, and there was no recognition of the mucositis or dry mouth, which we're going to talk about in much more detail now. So this was one of, and still is, one of the larger one of the larger reports describing cutaneous immune eruptions after immune checkpoint inhibitor. It's a single center study from Yale here from the United States, in Connecticut, and they had 98 patients who were treated with checkpoint inhibitors that developed a number of different, in this case, 103 different inflammatory eruptions. So in these 98 patients, only a minority, about just under 25%, actually required an interruption in treatment, meaning that they could actually continue treatment and manage the toxicity with either a systemic therapy or a topical therapy or whatnot. Most of the patients who required an interruption, most of those cases, almost 90%, included immunobolus, lichenoid, maculopapular, and Stevens-Johnson, so sort of more severe eruptions. And so they note that most rashes can be treated with topical therapy, but some conditions do require an interruption or even stopping. And it's an important take home from this paper because ultimately what happens in the skin is sort of a reflection of what we can also see happening in the mucosa. So when we talk about oral IRAEs, really a very highly variable epidemiology. Clinical features have included, that have been described and we've described, have been lichenoid or sort of lichen planus-like inflammation, a less specific erythema multiform-like presentation without those typical sort of lichen planus-like features, and rarely bullous or even mucous membrane pemphigoid has been described. There have been some sort of much less common descriptions. There have been a couple of cases of a pemphigus-like presentation. I was actually just talking with one of my residents on a project we're working on. We haven't seen sclerodermatous changes affecting the oral cavity or the face, but there have been some limited reports of patients developing a scleroderma-like condition, which we could imagine could potentially have an impact on the orofacial structures. And these typically occur about 3 months mean onset, but again, highly variable. And very often there's multi-system involvement. This is not just mouth, but we have had cases that are just in the mouth. Sicca syndrome or severe dry mouth has also been well described. Again, time frame can be highly variable, but interestingly with this condition, it tends to come on really, really strong. So it's like from one day to the next, the salivary glands just get turned off. And then there's some other kind of interesting, so there's a subset of patients who would have actually had undergone allogeneic stem cell transplantation for their underlying diagnosis and then had a relapse, and where there's an indication to treat with immune checkpoint inhibitor therapy. In that context, there have been reports of graft versus host disease being either activated or sort of reactivated, and in some cases quite severe and refractory disease. And as noted before, patients who are receiving combination therapy, meaning the anti-CTLA-4 and a PD-1 or PD-L1 blocker, will tend to have higher rates and potentially even more severe toxicities. For management, I think, the management aspect of it, there's really nothing new here. For all of you who know your oral medicine, our approaches to managing with topical steroids, topical tacrolimus, for example, can be very effective. Intralesional steroid therapy. There may need to be consideration for dose modifications, as noted from that study from Yale. With the Sicca syndrome, it's not really clear whether or not systemic steroids has much of a benefit. We can certainly manage people palliatively, and we can use prescription sialagogues. Patients who have really significant dry mouth, obviously there's dental considerations. They may need to go on fluoride. And for all these conditions, and not just for the mouth, of course, but for anywhere in the body, it's really important that there's an early recognition and diagnosis. So if necessary, patients can be referred to the appropriate specialist and/or treatment can be initiated. So we published this series now almost 2 years ago. We had identified 13 patients within our practice at the Cancer Center who developed oral, and these were all oral mucosal specific adverse events. Many more cases since. But I think for any of you who are interested, I know we don't have a whole lot of time this morning. I include this reference and would strongly suggest you read it. Provides some really nice images and figures, and a very good description of who these patients are and sort of what happened with them, how many required discontinuation or dose reduction, and how effective our interventions were for management. Here is an example of a patient presenting with this sort of erythema multiform-like presentation. You can see there's prominent involvement of the lip, lip ulceration and crusting, and with these sort of targetoid-like lesions on the skin. This was a case of bullous pemphigoid. It was actually, not surprisingly, biopsy proven based on these remarkable skin lesions, and patient presented with concurrent, quite extensive oral ulcerations as well. We didn't do further biopsy in the oral cavity at this point. And then the Sicca syndrome, it's interesting, you know, as you can imagine, like here, the oral mucosal toxicity tends to track pretty closely with cutaneous toxicity, whereas with the Sicca syndrome, this actually tends to be much more associated with inflammatory arthritis and other sort of rheumatologic manifestations of IRAEs. And again, I direct your attention to these papers that have actually described this toxicity very well, incredibly comprehensively, including with tissue biopsy, that's demonstrated that despite the fact that we would think of this as almost like a Sjogren's syndrome-like condition, the pathology is actually quite unique and different, although probably not so different from the pathology that we would see with condition like chronic graft versus host disease, where the salivary glands can be notably involved. And some examples of patients, you can see this patient has no saliva, very dry, atrophic appearing tongue, and not something we see regularly. We see this on occasion in head and neck cancer patients also after radiation therapy. But because of the profound salivary changes, this patient, and likely because of pH changes in the oral cavity, this patient has experienced an incredible amount of dental erosion, no dental caries, and actually no symptoms. So one more reference that I introduced to all of you here that I hope you might find interesting. This was almost sort of a follow-up paper that we wrote with some additional colleagues, talking about oral manifestations of immune-related adverse events, patients on immune checkpoint inhibitors as a review article, but really with the intent of trying to take the approach of that ASCO paper, where we would not only provide some management guidelines, but also recommendations as far as workup, a proposed grading system, and proposed management based on the grade. Of course, this is all a proposal, but no different than how that other paper was written. And, you know, we hope to see this sort of develop and evolve with time. So I may have gone a couple minutes over, but I'm more than happy to answer a few questions if we have time. In summary, so immune checkpoint inhibitor therapy is absolutely revolutionizing the management of cancer. Doesn't mean that every patient with cancer is going to receive one of these treatments, but for those who are receiving these therapies, it's really been a game changer. And this is just continuously evolving. I mean, if I can't follow every paper and every advance and every new sort of immune target, but it's really an amazing field. The IRAEs are actually quite common. They should be anticipated. And as noted, whether it's the mouth or elsewhere, they can have a really profound clinical impact. When it comes to the oral cavity, both the oral mucosa and the salivary glands are potential targets for IRAEs. We can use localized and targeted management that may limit the need for systemic therapy and or interruption of cancer therapy. And I will stop there. I thank you all for your attention and time. I hope the rest of this course goes well. And let me stop sharing. There we go. Dr. Alishbeg, do we have any time for questions, or have I cut into somebody else's time?
Thank you very much, Professor Triester. It is a very polished lecture, and we've been enjoying many new information, at least I was. I would now like to give the word to my junior colleagues who will ask audience should they have any questions.
Publiko, ukoliko netko ima pitanja za profesora Triestera, možete ga postaviti na hrvatskom, pa ćemo mi prevesti na engleski.
Apparently no questions. In that sense, I might abuse a little bit of your time. Can you discuss two things, please? One, regarding the percentages. How many patients have been treated in your hospital, and perhaps you would be able to identify the percentage of toxicities among them? Is it very low, extremely low? And the other thing, would there be any chance of trying to find some prognostic factors that would be able to identify people at risk of developing adverse events among those receiving immune checkpoint inhibitors?
Both excellent questions. Answer to the first question, off the top of my head, I don't recall the frequency. I think if you look at any toxicity, so not just mouth, but any toxicity, it's actually very high. I don't want to make up a number, but I think very high, like probably in the 80%, if not higher. As far as oral IRAEs specifically, we don't have a great sense. There's a paper that was published out of our group with Dr. Sonis as one of the co-authors, I think the senior author. I can't pull that up in front of me right this second, but that was based on a database analysis. So looking at sort of like all patients who had been treated and then going through the electronic health record and looking for specific terms that were in the notes and then actually looking and confirming. So to identify patients who had some sort of mucositis, stomatitis, or dry mouth, xerostomia, so on. It's not the cleanest approach because it probably captures things that maybe don't represent the exact toxicity, but that provides some fairly good figures that are probably at least good estimates. As far as risk factors go, for oral cavity specifically, we really haven't identified anything. I think what's been recognized was that slide I showed you, where patients who have a pre-existing immune condition, immune or autoimmune, those patients are at much higher risk, and in particular related to their underlying conditions. But it's really random. Like, why does one person develop colitis? Another patient develops thyroiditis. Another patient develops arthritis. Another patient develops bullous pemphigoid. Another patient develops an erythema multiforme-like reaction. Another patient develops a lichenoid-like reaction. It's incredibly variable.
Thank you. Apparently there is a question for you pending.
All right.
How many places in the world examine this kind of therapy that you do at your institution? Is there any institution in Europe that does it?
So when you say this therapy, do you mean the cancer therapy, or do you mean the interventions that we would do to help control?
We also use these drugs here in Croatia as well.
Right. Yeah. So I mean, they're used widely throughout the EU. I don't know, like, the approvals for the European approval versus the American FDA approvals. I have to imagine they're very similar, if not identical, for the most part. But like how widely they're available and or if there's associated cost, I think that's probably variable from country to country, and at least, even in our country, someone's individual insurance, like we don't have a national healthcare program. So some patients will actually probably have greater access to these therapies than others, even just because of the type of coverage they have.
Thank you very much, Nat.
Yeah.
It was a huge privilege for us that you have spared some of your time to
Thank you.
give a lecture, and it's just a wonderful opening of this conference.
Well, very good. And I'll leave you with my clinic at the Dana-Farber Cancer Institute starts right now. It's going to take me 10 minutes to get over there. I don't remember who I'm seeing today, but there's a very good chance I'm seeing 1 or 2 patients with these toxicities. I'll be seeing patients with graft-versus-host disease, jaw osteonecrosis, everything else. So enjoy your conference, and I hope to see everyone sometime soon. Take care.
Bye-bye.
Thank you so
Bye.
much. Bye.